In this video, we define the ECG criteria of left posterior fascicular block according to the current European Cardiology Society guideline. After this, find all of these criteria in real ECG example. As a next step, we explain the changes in the ventricular depolarization direction caused by left posterior fascicular block, with an explanation of QRS complex formation. And at the end of the video, we describe the rarity of left posterior fascicular block related to this differential diagnosis algorithm, and finally, etiological factors. You can use the time codes to check the most relevant information for you. So, the bundle of His divides into the right and left bundle branches. In turn, the main left bundle branch divides into several fairly discrete branches: left anterior fascicle, left posterior fascicle, and in up to 65% of hearts, left median, also called medial or septal fascicle. Left anterior fascicle normally initiates activation of the left anterior papillary muscle, the upper part of the septum, and left ventricular anterolateral free wall. Whereas the posterior fascicle travels to the posterior papillary muscle, and after to the posterior inferior parts of the left ventricle, the left ventricular inflow tract. Left median fascicle initiates depolarization of the interventricular septum. Left posterior fascicular block is an interventricular conduction disturbance of the left posterior fascicle. Let's check the ECG criteria according to the supplementary data for European Cardiology Society guideline on cardiac pacing and resynchronization therapy. There are rightward QRS axis between plus 90 and plus 140 degree, RS QRS morphology in first standard lead and AVL, QR QRS morphology in the second, the third, and AVF leads. QRS duration is less than 120 milliseconds. Also criteria include changes in Intrinsicoid deflection time and QRS slurring. Let's find all of these criteria one by one in real ECG example. Paper speed is 25 mm per second. Let's start from the mean QRS axis. For mean QRS axis estimation, we need to find the limb lead with the maximal R wave. In this case, the tallest R wave in the third standard lead. It is equal 10 mm. Lead with the tallest R wave indicates the mean QRS axis, but it should be also confirmed by the biphasic complex. The next step is find the lead with biphasic or near to biphasic complex. Remind that if R wave amplitude is equal to S wave amplitude, this type of QRS called biphasic. In our case, in first standard lead we have a near to biphasic complex, but with S wave greater than R wave. If QRS is true biphasic, R is equal S. That means that lead with biphasic complex is oriented at 90-degree angle to the mean QRS axis. In our situation, S wave is greater than R wave in first standard lead. That means that mean QRS axis is oriented more than 90 degrees to the lead with biphasic complex. Now let's use hexaxial diagram and mark the lead with maximal R waves. Now let's mark the lead with biphasic complex. If R and S had been equal to each other, the mean QRS axis would be plus 90 degrees. But in our case, S is greater than R, so the mean QRS axis is more positive than plus 90 degrees. Therefore, alpha angle of mean QRS axis is plus 120 degrees. So the first criterion of left posterior fascicular block is present. Now let's check the QRS morphology in the limb leads. As you see in first standard lead and AVL, QRS has RS morphology with small R wave and large S wave. Remember that if the amplitude of a wave is less than 5 mm, it is named by the lowercase letter. If more than 5 mm, uppercase letter. As a next step, let's check the QRS in inferior leads, the second, the third, and AVF. In second standard lead, QRS has RS morphology with large R wave and small S wave, and it doesn't fit the criteria. In third standard lead and AVF, QRS has QR morphology with small Q wave and large R wave. So the second criterion is present with the second standard lead exception. As a next step, let's check the width of QRS complex in second standard lead. in the case of 25 mm per second paper speed, two small boxes are equal 80 milliseconds, which is less than 120 milliseconds, so the third criterion is present. The next step is Intrinsicoid deflection time measurement. Intrinsicoid deflection time is the time from the onset of QRS complex to the peak of R wave. So in AVF in V6, it should be greater than 50 milliseconds, unlike the AVL, where it should be less than 50. As a result, in AVF, intrinsicoid deflection time is slightly more than one small box, and it is equal 50 milliseconds. By the way, 25 mm per second paper speed is not so comfortable for such an accurate measurements. In V6, intrinsicoid deflection time is equal one small box or 40 milliseconds. And in AVL, intrinsicoid deflection time is slightly less than 40 milliseconds. So the fourth criterion is present, with an exception of V6. The last ECG criterion of left posterior fascicular block is the mid-terminal slurring on the QRS in the second, the third and AVF leads. But firstly, let's define the slurring on the ECG. So a deflection is slurred when it displays a distinctive change in slope. QRS slurring can be found as an X-angle between the initial and terminal part of R-wave downslope. Let's check. As you see, the second standard lead doesn't have QRS slurring at all, but the third standard lead does. The same we see in AVF, that confirms the left posterior fascicular block with some limitations that are connected to the second standard lead and intrinsicoid deflection time in V6. Now let's describe how the direction of depolarization is changed in the frontal plane in the case of left posterior fascicular block. Under the normal conditions, conduction via left anterior and left posterior fascicles proceed simultaneously, such that electrical activation of the left ventricle is uniform and spreading outward from the bases of two papillary muscles. In the case of the left posterior fascicular block, depolarization begins via left anterior fascicle alone, at the anterior papillary muscle, and then spreads to the rest of the ventricle. So during the first stage of ventricular depolarization, left anterior fascicle activates anterior papillary muscle and a small part of anterior and superior regions of the left ventricle. Now we add the XXL diagram for understanding the direction of depolarization and logic of QRS formation. So in first stage of depolarization, the vector of depolarization is directed upward and toward to the patient's left side. We move the depolarization vector to the center and draw the projection of depolarization vector to the leads by using perpendicular lines. If the depolarization vector projects to the positive part of lead, ECG shows a positive deflection. As a result of first stage of depolarization in AVL and first standard lead, ECG shows a lowercase lambda. The same initial vector of depolarization projects to the negative part of second standard lead. As a result, ECG shows a small negative deflection, Q wave. The same initial vector of depolarization also projects to the negative part of AVF and third standard lead. As a result, ECG also shows a small negative deflections, Q waves. During the second stage of depolarization, depolarization propagates downward and to the right, toward to the blocked region. The vector of depolarization is directed rightward and slightly downward compared to the previous stage. It projects to the positive part of AVL and first standard lead that makes the R wave bigger here. The same vector projects to the positive part of second standard lead. Therefore, here we see a positive deflection, R wave. The similar picture we see in AVF and third standard leads. There are positive deflections, R waves. The last depolarization stage is oriented even more rightward and downward. So the depolarization vector projects to the negative parts of AVL and first standard lead, causing deep S waves here. The same vector projects to the positive part of the second AVF and third standard leads and causes high R waves here. This is how the ECG criteria are formed in the frontal plane. Left posterior fascicular block is the rarest of all intraventricular blocks and extremely unusual when isolated. According to the data, it belongs only to 0.1% of all intraventricular conduction defects. In population with myocardial infarction, it belongs to 0.1% of cases. So this type of ventricular conduction block is extremely rare. It occurs so rarely because the left posterior fascicle is the least vulnerable division of intraventricular conduction system. Let's explain why it is so rare in comparison to left anterior fascicle. Let's start with anatomy. Left posterior fascicle is thicker, as a result has a greater conduction speed. Also, it has double vessel blood supply from the left anterior descending artery and right coronary artery. At the same time, left anterior fascicle is supplied by the left anterior descending artery alone. And the last criterion is topography. Left posterior fascicle runs through the more protected area, left ventricular inflow tract, with less mechanical pressure impact. On the other hand, left anterior fascicle runs diagonally through the subendocardium of the left ventricular outflow tract. This region is subject of a great turbulence and high pressure. All of above defines the left posterior fascicle as the least vulnerable division of interventricular conduction system. According to the criteria of left posterior fascicular block and especially right mean curious axis deviation and rarity of left posterior fascicular block, to avoid misdiagnosis, you need to exclude more common causes of right mean curious axis deviation, which includes left-right limb electrode misplacement. Sometimes right axis deviation is a normal variant, all causes of right ventricular overload and hypertrophy, all myocardial infarction with the Q waves, right bundle branch block, pre-excitation syndromes, and dextrocardia. As a result, left posterior fascicular block is a diagnosis of exclusion. Now let's describe the etiology of left posterior fascicular block. It can be caused by different infiltrative cardiomyopathies, which includes amyloidosis, sarcoidosis, and others. Another reason for left posterior fascicular block are Lenegres and Lev syndromes, which are associated with fibrosis and sometimes calcification of the proximal conduction system. Left posterior fascicular block travels through the left ventricular inflow tract and can be affected by the mechanical effect of jet of an aortic regurgitation on the posterior portion of the left septum. According to this, left posterior fascicular block can be caused by aortic regurgitation, stenosis, or both. One of the main reasons for left posterior fascicular block is coronary artery disease, especially inferior myocardial infarction. We already know that posterior fascicle has a double blood supply. Consequently, manifestation of left posterior fascicular block can be sign of multivessel disease. Inferior myocardial infarction can be complicated by the rupture of inferior part of interventricular septum that lead to acquired ventricular septum defect right in the place where the posterior fascicle is passing through. I add the ECG criteria of left posterior fascicular block one more time, just for visual memory stimulation. If you like the content, press like and subscribe buttons and have a good day.